So we are excited to have each of you with us today, and we are ready to have a lively conversation around questions that are top of mind for lots of providers and healthcare organizations. As a reminder, you can join our conversation by using Twitter and the hashtag #PoundHealthITExperts. It's #PoundHealthITExperts. So let's go ahead and get started here. This past May, we polled 35 C-level healthcare executives at the Midas Plus annual symposium to get their perspective on population health management. And the group of executives collectively represented about 80,000 beds in more than 480 hospitals. And we asked to provide their perspective on population health management, starting with how it should be defined. So according to this group, the most important requirements of population health management and having a program in those areas are that it facilitates care across the healthcare continuum and that it supports providing the highest quality care at the lowest cost. So Bernadette, why is population health management becoming more significant and necessary?
Well, we are spending way too much on healthcare, and our outcomes are not good. And now we have a little bit of handle on why some of this is going on. And a whole swath of the nation is getting too much healthcare, overdiagnosis, overtesting. A whole segment of the population isn't really getting enough healthcare, and certainly not enough preventative intervention. And too many are not getting exactly the right care at the right time. So what population health data brings us and brings to the clinician, which I think is going to be very valuable, is context of the patient. What's going on in your patient's life that will make this treatment that we're talking about optimal and really work. And we really need to have a much better handle on our patients before we're able to do that.
That's great, Bernadette. And really, I should introduce you to the entire group. Bernadette Keefe is a physician and aging and mobility expert. We also have our other panelists with us. Dan Munro, healthcare innovation and policy reporter and Forbes contributor. Janice McCallum, Managing Director of Health Content Advisors.
Hi.
And then Deryk Van Brunt, the Senior Vice President and General Manager of Healthy Communities group within the Midas Plus Xerox Company. So, and myself, I'm the Managing Director of Midas Plus, a Xerox company. So we're excited that you're here to hear more from these experts here on population health. So sorry about that, guys. So I'm so glad you're here. Bernadette, great response there. Dan, any thoughts on why population health management is becoming more significant and necessary?
So yeah, my view is a little different in the sense that I have to look up population health management, and as far as I can tell, the first occurrence comes out of Canada, circa 1993. And so based on that, I think the idea around population health is really, truly population health. So we've co-opted it a little bit to sort of apply to selective health populations, and then we call that population health. But I think the larger issue around population health is truly population health. And it's one of those sort of bingo buzzwords that we've gravitated towards. And it's not unlike some of the other mechanisms that we're targeting in the sense of going from volume to value, ACOs, precision medicine. All of these require large amounts of data in the sense of getting to what's effective and at the population level, whatever population that may be. And so I'm a big proponent of the kind of data that we need to help us on our road to this kind of transformation.
Right. That's a very good point. So Janice, what would your thoughts be in response to Bernadette and Dan?
Well, I would just add to what they've already said. I look at the IOM definition of population health, the Institute of Medicine. Basically, it can pertain to any population. The outcomes of any population are, as small as 2 or 3 people to the entire population. And I think that's where some of the confusion comes in, because it can be used to in so many different ways. The ability to segment by populations and focus on personalized care for a particular population, I think, is a critical part. But as Dan said, the ultimate goal of serving the entire population as best as we can, work toward prevention, is the brass ring out there.
Right. And Deryk, how does this fit with the value-based? What are your thoughts on the value-based care?
Well, value-based healthcare reimbursement is really going to compensate providers based on successful care outcomes, and to do that, you need to have, of course, effective care management, but that includes prevention. And once you start introducing prevention into the reimbursement for providers, that really changes the paradigm, and suddenly you're down the path of population health management. It's interesting to note that in the Midas Plus Symposium poll that was done that you referenced earlier with the C-suite executives, over 80% strongly agreed that population health management is necessary as the U.S. shifts towards value-based healthcare. So we're starting down this path, and it's just a question.
Looks like we lost Deryk's connection there, so let's keep rolling here. I'm going to skip down to another question here. The next question I actually had queued up there for Deryk, so hopefully he'll be able to join us back here in just a few seconds. Dan, let's have this next question for you. So, as with any health IT or digital technology, we all know the consumers alike express some concern around security and privacy, and then sometimes I think policy and lawmakers express even more concern about security and privacy. Where do you think we're at generationally? How do you think the generations come into play? And would love to hear what you've discussed in some of your recent articles. What are some of the other challenges providers have when it comes to implementing these effective population health management programs?
Yeah, so security and privacy are key, and already in the course of less than 12 months, the healthcare industry as a group has effectively lost about 96 million health records from various institutions. Anthem was probably the largest single at about 80 million, and a lot of these aren't health records, but they're privacy records that are maintained by health entities. So it's really a broad brush against sort of the health industry. But here's the larger issue, is that we don't have the standards that we need in order to get to the kind of privacy and security that's pivotal. And so we've tended to think in terms of security being relegated to individual entities without standards. And I would argue that we can't get to the kind of security and privacy that we really need without standards that help us with that nationally, and then also the kinds of technology that you can bring to bear for better security with standards than what we have today, because much of what we use today is reliant on things like social security number and a name. And if you look at a hospital, the process in a hospital of trying to identify who the hell we are when we arrive is Byzantine, and it's prone to errors, and every hospital does this differently. And so what I think we need to get to quickly is to engage the government to help us with that standards process, because it's a lot like vehicle identification numbers. The auto manufacturing industry had a similar problem in the 50s up until about 1980 with identifying vehicles nationally, easily and quickly. And the government stepped in and said, hey, here's a VIN that's based on an ISO standard, and it's a 17-character number that's now printed on pretty much every major part that manufacturers use for auto manufacturing. So we could do something similar in healthcare, and I think we should.
All right, Janice, what are your thoughts on privacy and security? Do you feel the market is really really sensitive to that, and what do we need to do around those areas?
Well, I think a lot of technology solutions are available, but as Dan said, there's no standard solution. But I think the problem he's referring to with the lack of a national or lack of a patient ID or uniform patient ID is definitely a problem. To do this probabilistic matching just doesn't work very well. I've done some work in the financial services industry, for instance. Every stock has a CUSIP number. Because there's a lot of possibility for confusion without that. So it's in information technology. It's a natural to have a unique ID, and that's missing here. The only other thing I would add is, on the theme of population health and a spectrum of individuals in that population, some people have a higher degree or a higher need for privacy than others. There's a lot of evidence that patients with rare diseases, for instance, will do almost anything, contribute almost any information they can if it's going to help lead to a cure. So it really needs to be up to the patient. There has to be some kind of graded consent framework to help there, and I don't think we're too close to that yet.
Yeah, I think that's a really good point. Bernadette, what are your thoughts on that?
I completely agree. Patients, well, someone just tweeted out this morning that, and I've forgotten the link and what this was, but I thought it was very interesting. They had gone ahead and released all their medical records publicly, and this has been for more than a few years now, and all their families. And when I read, I thought, well, that's really interesting. And so I looked at what was released and the history, and there wasn't really anything embarrassing. So really, in his life, he had a nice existence, but you get someone who has an addiction, mental health issues, reasons that might affect their employment, all the things related to the social determinants of health. Those people are going to want to protect their data. They don't want every physician seeing all that data. So I don't know how we're going to work it out, but some things must remain private. Thanks.
Right. Yeah, that's really good. So Deryk, it's interesting. I'd like for you first to respond to the privacy and security side of population health, and then kind of cue you up for the next question, which really has to do with talking about social determinants of health. So let's start with privacy and security, and then we'll have you kick off one of the next questions from the group.
Yeah, that sounds great. And I'll just echo this need for standards around privacy and security. And if we, just start with the poll at Midas Plus Symposium poll, the number one challenge that these C-suite executives said that they need to address to begin to really get serious about population health is having interoperability of systems. So it very much reinforces what we're talking about. They also mentioned several other challenges with population health, which includes the lack of financial incentives, poor coordination across different care providers, and just the need to have the ability to create meaningful data that provides actionable insights, whether it's to patients to engage them to take positive action, or to clinicians to help them make more personalized healthcare decisions. So these are all various issues that are challenges to really move down the population health path. To move to kind of the determinants of health, this is just a huge area and one that I spend a lot of time in, and it's only, I think, by looking at the broad determinants of health that we really can make substantial change in improving health outcomes and gaining efficiencies. One way I look at this is I start with the CDC's determinants of health. They have this pie chart, and there are 4 major categories.
So Deryk must be having troubles out there in the Berkeley area Janice or Bernadette or Dan, you're familiar with the grid that Deryk's referring to.
Yeah.
But where 5% of the determinants of health, a little around 5% has to do with genetics, and about 15% with medical care, leaving the rest of the 80% of the pie to lifestyle, behavioral health, behavioral choices, social and environmental impacts in these determinants of health. And I think when we talk about this population health matrix, right? It's not spreading peanut butter evenly across everybody, because everybody's has different needs and has different ways of engaging and different personal things that are impacting their decisions and their lifestyle. I'd love to hear, Dan, let's start with you, your thoughts, and then we'll, Bernadette, let's just kind of talk around the group here, and Janice as well.
Absolutely. So this is actually a topic that I'm covering in the book that I'm working on, and it's absolutely a big element, because what we're talking about is lifestyle and behavior change, and getting to behavior change is really, really hard work, and it's a long timeline. I'll give you an example. There's probably no other single determinant of health, personal, that we each make than smoking, and we've been at the process of trying to wean the country and the world off of this carcinogenic product for well over 45 years. And in the course of 45 years, we've made great progress. But we've taken the statistic from about 45% of Americans who acknowledge that they smoke down to about 20. That's great progress, but it's not zero. And the timeline for that is 45 years. And we can look at the same thing relative to obesity, which is the other one sort of behind smoking, relative to a major lifestyle choice. And obesity is another one of those where Dr. Dean Ornish said it best when he said, in effect, the cheapest calories to buy are the most expensive. They're most expensive on our health. And he's absolutely right. If you go down to a McDonald's, a cheeseburger is 99 cents, a salad is $5. So there's an economic component to almost every element of behavior health that we're trying to target.
And Bernadette, I see you nodding your head. So
yeah, thanks. Yes, I mean, we're talking here food deserts, okay? Huge swaths of the population, the underserved population in general, having access to the corner store that has is just either has fast food or just snacks, and that's brought home for dinner. And there's no fresh food access at all. That is an issue that we're going to have to address, because if people don't have access to good food, they can't get better. They can't get healthier. So I mean, there is some. I mean, actually, healthcare systems are starting to put fresh markets there, in neighborhoods and things like that. But it's a little bit here and there. In my opinion, we need a living wage. That'll help people, and we also need to look at those neighborhoods and have public incentives to get good grocery stores in there, or just a regular, normal grocery store that carries produce.
Right. So Janice, your thoughts?
Yeah, just listening to Bernadette, I can't help but mention that my sister, who just went back to Florida this morning, her husband had open heart surgery not long ago, and in the lobby of the hospital is a McDonald's. I don't think the healthcare system has done a very good job of really promoting healthy eating or giving patients information they need to make healthy choices. I don't think they've served that need well at all, and I think it's an area where we really do need to bring together public health and private medicine and data, because I do think that showing people consistent data may actually change some behavior. There are many people out there who don't have basic knowledge about nutrition and just don't see the connection between what they eat and their health.
Right. And, even these small movements, right? While we're on food, just things being on menu, calories being on menus, makes a big difference, right? I know it changes my choices at times. So while we focused in on food, Deryk, knowing that the company you started and have been running, what are some of the other social determinants or environmental and lifestyle things outside of food that you think we should talk about?
Well, as I was saying earlier, over 50% of the determinants of health have to do with lifestyle and the physical and social environment. And I think, let me just take an example that's really powerful about how we can almost re-engineer our processes to improve health outcomes and gain all kinds of efficiencies. And if we look at San Francisco, for example, there was a group that looked at data across all of San Francisco, not just within any given hospital. And they noticed that there were very high emergency room rates associated with alcohol abuse. Now, it's not like anyone woke up that morning and said, I wonder what's going on in San Francisco with respect to alcohol abuse. So they studied that. They looked at sort of GIS maps in the community. They found pockets of where these where the folks that were coming into the ER for this purpose were coming from, and it was from two different neighborhoods, one of which had a lot of homeless people there. So after some analysis and the rest, they basically created something novel called the Sobering Center. It's a physical place so that emergency crews would take people there instead of to San Francisco General ER or one of the other hospitals to make a long, and that Sobering Center is staffed with a physician and caseworkers and really does a marvelous job. Well, that Sobering Center, the entire cost of the center, which houses 10 to 14 people per day, is less than the cost of one ER visit through a traditional method. So it's a 10-to-1 return on investment. San Francisco is saving over $9 million a year on this one program. And frankly, the people are getting better served because at discharge, there are caseworkers that specialize in that area that are helping them with a broader set of issues having to do with their homelessness or other issues around that. So this is an example of re-engineering, stepping back from the data of just patient, physician, one at a time, fee for service, and looking broadly at the community, and whether it's a lifestyle issue or a physical, determinant of health issue or other issues, to start taking sort of top-down and systematic change. And it's very exciting, and I think we'll see a lot more of this.
Right. So it is intriguing, and I guess, Janice, a question I'd have for you, especially with your background, is, just when is this gonna, what medical data do we need to get into patients' hands, and what are the challenges? Because we're talking about patients, we're talking about them being informed, we're talking about engaging with patients being able to make, or members of society, not just patients, but members, right? Our communities being able to make wise decisions. How do we get information into their hands that they know what to do with?
Well, I mean, there are incentives for healthcare providers to make information available to patients, but it's not being implemented very successfully, let's say, and I think there's still a lot of resistance to giving patients data for fear of the questions that will be asked about it, that patients won't understand the information, that if you get down to the level of the physician notes, it may change the nature of the relationship. So there's a lot of concern on the part of the physicians, but the evidence has shown, and I tweeted out a link to a report or an article written by Sue Woods, tweeted out earlier today under this hashtag. She works for the VA, and their experience has been contrary to that, making the information available, sharing information leads to better outcomes, it leads to more self-care. She also references e-patient Dave. Most of you have probably heard of Dave. He wrote a book called Let Patients Help. Yeah, I'm trying to wanted to make sure I didn't confuse it with another title. But one of his favorite sayings, and I'm paraphrasing here, I'll probably get it a little wrong, is, it's unfair to keep patients in the dark and then accuse them of being uninformed. I mean, we really have to get better at sharing the information. it's too difficult. There's still too many barriers to patients having access to the information, and we can do so much more than just give them information from their chart. We really should be able to give them information to help them make sense of that chart.
I totally agree with that. I think that the feeling of many physicians, and I'm just going to speak more for them. I think I would be just a go-ahead at this point, but is there are a lot of different things coming at once that are challenging their time, and I think they're just a little paralyzed, a little worried that they really can't manage anything more. But what I would like to see is, first of all, I do agree that they're very squeezed, and I think that there should be totally open kind of sharing of data completely, because that's going to help health literacy. It's going to help people take care of themselves. But also, physicians need a lot more support from teams. They need a lot more support from hospital systems. They have to learn a little better to work in teams, and people need to be able to work with them at the top of their license, so that really the patient is much better served, kind of has a team approach, so that some of the questions coming through can be well answered by a team. It isn't just all falling on the shoulders, but that takes the will of everybody wanting to work as a team from the top to the bottom of the organizations, and I am a real fan of teamwork.
Great. Dan, your thoughts?
Yeah, so I agree 100%. This maps back to what Atul Gawande said years ago when he talked about the need for pit crews as opposed to cowboys, and that maps back to the kind of system that we haven't really designed or engineered. It's sort of evolved, and the evolution of our system is such that it has some systemic flaws that have yet to be addressed. We still rely on employer-sponsored insurance, and that raises a big question. Is that a good mechanism for providing health insurance? Should the employer be the fourth party, if you will, in what amounts to a three-party system in every other industrialized country? Should we have universal coverage as opposed to what we have, which is selective coverage? We select based on age, based on income, based on employment, based on different variables, and then we complicate that by an annual mechanism called enrollment. Well, the administrative burden to that for everybody is enormous, which is how electronic health records got started. That's really the entry point for electronic health records, was to help navigate this administrative nightmare for billing. And we do that every year. And the whole system sort of revolves around this yearly process of determining who has coverage through what provider and through what network and through what payer and through employment. And so when you layer that in, it becomes an enormous burden that we've lived with since literally World War II. The question is time for a change.
Right, Dan, I think that's an interesting point, because when I speak at different events all over, I've shared with each of you that, you know, in a room full thousands of top healthcare executives, top healthcare thinkers, I say, raise your hands if you haven't a PHR today. And a few people will raise their hands, and then I say, oh, how many people actively are engaged with that PHR, use that in their care? And one or two will raise their hands out of thousands of the top thinkers. So I think, personally, one of the big challenges is how do we get this to align, and one of the things is incentives, right? When we did our poll at our executive session with these executives, we said, what are some of the top barriers? One of the executives' answers were, first of all, data interoperability. We talked about that. But right on the tails of that were financial incentives. You know, we have 50% of our nation that's not on an employer-based health plan right now as well. So they're not on a high deductible plan that creates a different behavioral model, right? My employer can put me on a high deductible plan, and I can begin to maybe drive some of my incentive behaviors and my family's incentive behaviors, or maybe we pay attention to our biometric screenings because it lowers our premium. We also have 50% of our nation that's not on an incentive model like that at all. So that's another interesting challenge of how do we drive societal behavior change as well. Deryk, I see that you were able to get connected back in here. Thoughts when we talk about the challenges, other than the challenge of you staying connected, and maybe challenges to healthcare from that standpoint, to getting the population health to what are our barriers there? How do we get this rolled out?
Well, I think that we've been talking about a lot of the key pieces. So there's a technology component around interoperability and data security and privacy. There are the alignment of financial incentives, which I think are absolutely huge. I mean, they're bigger than the technical issues by far, in my opinion, in that we all want to do the right thing. Physicians want to do the right thing. They don't have time because that's not how their organizations are structured, and that's not how their time is essentially being requested for them. In fact, it's almost impossible for them to really take those extra steps without the data necessary and without the time. It's not just about money. It's not about greed. It's about how we organize and what we emphasize. So that said, I think the other thing that's absolutely vital is that we improve not just the availability of data, but the decision-making that we can make with the data, so that we can gain actionable insights and have easy access to best practices, whether that's to clinicians, whether it's to patients, or to stakeholders at a community level looking at the broader population health issues. Let's just take patients as an example. We know that if you just give someone information, if you tell a smoker, a physician says, stop smoking, that doesn't have a lot of effectiveness. So what you really need is to look at where people are in their sort of stages of change and make sure that at all times during that period they've got access to the right information, the right tools to make change. Mm-hmm. And we have built some of those applications and they've had some good success, but when we're into real population health management, we're going to have all three of these things. Interoperability of data, so we've got infrastructure, alignment of financial incentives, but then really much better tools for decision making for all the different stakeholders, and we're still building that.
Yeah, absolutely. Deryk, would you feel comfortable also expanding maybe some of what you've seen? I feel like it's really relevant to the comments that have been made, and I'd like the whole group to kind of respond to Deryk's feedback here. But Deryk, talk about a community's responsibility, or what you see communities doing with these collective action groups, and what we may say while we're talking about EMRs and interoperabilities and systems and doctors. There's a whole structure here that's important to helping our population and our society improve their health. So can you talk a little bit about some of the examples you see out across the nation of collective action groups that you work with?
Yeah, it's a very exciting development, and there are a variety of different methodologies. I'm just going to describe one briefly, but there are others. There's one sort of methodology called collective impact, and I believe it's out of Stanford. Yep. And it's really the idea is that to improve the health of the population is greater than any one organization, including the dominant hospital in that area. That really you need to be looking at from when people are born to when they pass away and all the different things that are going on, as we've been discussing in this hangout. And so what collective impact does is it says you get different stakeholders together. So for sure you have healthcare delivery providers, you've got payers, but you also bring in United Way. You bring in churches, you bring in local government, you bring in schools, economic development banks. I mean, it's all the major players. And what they do is really look at what are our priorities in our community, because each community's got a different profile of what the issues are that are really driving poor health status. And everybody cares, and maybe they care for different reasons. Some care because they're really interested in seeing productivity in the region. Others are interested in economic vitality. Others are purely motivated by just health status. Well, guess what? They're all wrapped up in the same thing. So rarely are there challenges in finding priorities amongst these stakeholders. And then what they do is the first thing they need is data. Where are we now? Where do we want to be? And what are the best practices to get there? So this is what we refer to as outside-in kind of thinking, and it's, I have to say, almost sweeping the nation, but it's in an embryonic form in that the groups get together, they want to do the right thing, they have a methodology, but they're often a bit hamstrung with access to real data and evidence-based programs and policies that can help them address their issues. Because it could be anything from, you know, improving physical activity, to smoking cessation, to traffic accidents. There's really a wide range of issues, and that's who we work with around the country to put these into place. And the effectiveness of this, like I gave the San Francisco example earlier, can be very powerful, both economically as well as improving health status.
Right. Bernadette, any thoughts you'd like to add to this? I think you're on mute, real quick.
Got it. I think this is great. I really think community work, community outreach is huge. And what I've read about too is a lot of this business with health ambassadors in the community. So you get people that are respected in the community. They almost suggest certain people to become health ambassadors for that community. They either come from the church or from certain social groups, and through various through various organizations within that community, elevate both the health literacy and healthy behaviors. So health ambassadors brought out from the community, I think, is another wonderful method. And just to mention that that we're really going to need lots of attention with respect to our aging population, because that's a whole nother situation.
Absolutely. Dan, any thoughts?
Yeah, so this maps back a little bit to you know, Governor Kitzhaber's story of air conditioning, and I don't know if everybody knows that one, but it's a great story because the way Medicare is set up today, it's perfectly content to pay for a $40,000 emergency cardiac event for an 80-year-old woman who lives in an apartment, when in fact what's really needed is a $300 window air conditioner. So we absolutely need to change our thinking. The challenge that we have relative to preventative health care, which is where I map back to Mark Bertolini, who talked about this in his HIMSS keynote 2 years ago, when he said we absolutely need to make the preventative bet, and we will do that. But that's a 25-year or a 20-year horizon in terms of getting to sort of an ROI. And yes, we need to do those things, and we will do those things, but there's some more immediate issues relative to the population of healthcare, in the sense of trying to get to a new model of care in the interim while we execute against preventative models that will have a long-term payback. Yeah,
that's really, couldn't agree more. So Janice, we've got a question here from Alfred. Do any of the experts, let's start with you, Janice, believe it is possible to de-identify individual patient data when used for broader research?
Well, there's...
I can answer that because technically, yes, it is possible.
Yeah.
So, I mean, I actually have a computer science degree, and so I've done software development, so I can tell you firsthand that the technology behind that is absolutely possible.
But I would add, as we're getting into more big data and aggregating more data together, it's going to be easier for somebody who is driven to try to identify or re-identify some people. It's going to become easier, especially when genetic information is there. I think maybe we shouldn't be so concerned about the ability to re-identify information and de-identify it perfectly. I think the consent process is probably a better way to approach it, because not everybody is going to be that concerned if their information is out there. We just have to be careful. Well, I mean, obviously there's different ways it can be used, and that can be a big problem. But yeah, there are well, I'd agree with Dan, but I also think that once you get into aggregating a lot of different sources, especially genetic information, it's, you know, somebody's driven hard enough to want to do that, then yeah, they'll be able to re-identify it.
Right, right, and that goes back to that privacy and security side of things. Any thoughts, Deryk or Bernadette? On that, you guys are good. So while we've got some other questions kind of queuing up here, but while I'm waiting on those questions, let me start with Bernadette. So I'm sure it'll be an easy question. So when are we going to arrive at this nirvana? And what are your thoughts? When do we get there?
Well, it would be nice if I thought it was going to be soon. There are a lot of moving parts and cats to herd and cultures to change, and a lot of them Dan brought up. I mean, huge issues. So I'm not even going to give time. But with human endeavor, good things are difficult, Aristotle said, and we just keep going.
All right. So, Deryk, how about you? Since Dan and Janice took a shot at that last one, when are we going to arrive, or what does arrival even look like? You're on mute, Deryk.
Thank you. I think the first thing is to say that population health will come in pieces, I suspect. You know, it's not just going to happen all at once. And probably the most important lever on the speed with which these pieces come into play is back to the financial incentives that we've talked about. And I'd really like to compliment CMS, despite how difficult it's been, that they're inexorably pushing towards the kinds of reimbursement and setting the stage for what we're doing. But it's, I'll give you one sort of data point at this executive summit when asked about population health management and the timing. Basically, about 2/3 of the executives said that they will begin delivering a fully scaled population health management system within 5 years. And about 1/6 of those polled said that they're already well along the way right now. So I think that, you know, we've started. There will be significant pieces to come into play, and I think, you know, to Dan's point earlier, this will happen in waves. There's shorter term, you know, kind of low-hanging fruit where you do more of a defined population risk stratification and optimize your healthcare delivery and look at some of the prevention and better management issues. And then it'll probably evolve a little bit into more of this community-wide population health management, because there's some low-hanging fruit there that we can really go after fairly quickly. And then there will be, you know, this whole really empowering individuals to make better change, which will be a bit more of an investment. But eventually, I hope, if we jump out, and it might be a generation, we really will have, whatever the form is, maybe it's a social bond or something along those lines, we'll be making these serious investments in education and health and productivity, because we'll actually know the return on investment that comes from that. And these are the experiments that will create the knowledge base that we can build on before we're ready to go to scale. So, short answer, over the next 5 years, I really think we'll see substantive change, but it'll be a generation before it feels more broad-based.
Right. And I think that tees up well the next question here from Colin Hung. So Dan, I'm going to direct this first to you, because I think that education, we've talked about health literacy as well. So I'm going to reform Colin's question just a little bit, which his question is, how do you overcome public apathy, and I'm also going to say health literacy / education about health, so apathy towards health, and then is that all up to public health, or who's that up to?
So there is a responsibility sort of on the part of everybody, but it does change throughout sort of a person's life, and we have to be realistic about that as well. They're not called, you know, invincibles young and invincibles for lack of a reason. I mean, it's a defined term in insurance coverage. When you're that age, you tend not to think in terms of healthcare needs, or you're already presented with healthcare issues that require interaction with the healthcare system that's problematic. And I go back to Anna McAllister-Slip, who's a type 1 diabetic. And she has 4 different prescription devices that she uses for managing her type 1 diabetes on a daily, hourly, minute-by-minute basis. And these 4 electronic devices are really miracles of technology evolution. None of them communicate with each other. So, in effect, she has these great tools that are available to her, and yet the data that comes from them isn't available to her in a way that makes her life easier. It actually makes her life harder. And it goes back to also what Paul Levy talked about with his experience of data and portability of data with a patient who presented to an ER, and they did an MRI or a CAT scan, and they couldn't get the data to the hospital, and it was less than a mile away. And so what did they do? They wound up burning the data onto a thumb drive and having somebody walk the data 3/10 of a mile for the emergency procedure that was necessary. And this is 2015. This isn't like it's 1990. And yet we're still walking around with thumb drives in healthcare as a way to protect and secure data and privacy. And it's just stunning to me. So back to the question, in the sense of apathy, some of this apathy is natural on the part of consumers when it comes to healthcare. When they experience an ATM transaction with a credit card that's universal, they can go to any ATM with a card and pull cash out. It doesn't matter whose ATM it is. But heaven forbid you should be able to do that in healthcare. You can't. So there's a natural barrier that's been set up, and a lot of those barriers need to be addressed and then broken down. Right.
Yeah. Health is such a long-term thing where until we have an event, we get to that teachable moment as well. It happens, or one of our loved ones, one of our parents has an event, and suddenly I'm very engaged to engage in my care. I think one of you shared a story about that the other day that was I thought very on point. Janice, we've got a question here from Pop Health Chick. It's a great question that kind of allows you to provide your overall thoughts here. So, how can we improve care outcomes?
Well, just pulling together some of the recent comments or recent discussion, I think one of the ways to engage patients more in their care and improve outcomes is to become more personalized in the care that's given. And we talked about evidence-based information. Well, in healthcare, the evidence-based medical information is based on some fairly limited sources now, and population health is going to help us segment that better. In retail, we know that there are systems, customer relationship management systems, that really help customize deals for a particular patient, for particular consumers. The same type of thing, that same kind of process can be used in healthcare. We have a way to go still, but if your clinician is talking to you in a way that makes sense, if you're operating under shared decision making, so that you feel like you're being listened to and what is being suggested makes sense to you, I think that's a terrific way to make progress. But also, back to the whole data theme, we're just now tracking data on outcomes and analyzing it. So clearly, being able to look back and see what kind of complications occur in certain instances in certain populations is going to make a big difference. There's a lot of pieces coming into play that are going to make a difference, but it's complex and it's not going to happen overnight.
Bernadette, if you were to pick those top 3 to 5 things that help improve healthcare outcomes and start to get us there, what would you outline those to be?
I think that patients really need to feel supported. They need to feel that they're being listened to. They need to understand enough about their bodies and have enough health literacy to be able to express what their illness feels like. They also need to come in, and their families need to come in having talked about some of the difficult issues around goals, let's just say around end of life, different kinds of things with respect to treatment, because we know that sometimes really doing a different type of care, supportive care, palliative care, hospice care, is what we should be doing for, say, the elderly congestive heart failure patient. Yes, they still need maybe some meds, but they definitely need supportive care and very light touch. So at every stage, and the millennial, yeah, they're invincible. Let me tell you, I know that. So they need to feel that the system's going to respond. They want a nimble system. They want it mobile. They want it cheap, and they want it easy, and they want it 5 minutes ago.
We are on, I mean, all the experts on the panel are still part of the Invincibles, right? We're all still the young Invincibles. Isn't that right, Dan?
I passed that a few years ago. I'll confess.
So Dan, any thoughts here on
coaching?
Yeah. Any thoughts, Dan, here on how we get there? What you'd like to share with our audience and your fellow panelists?
Yeah. So I'm still seeing, sort of large systemic flaws that are going to and probably will come up again in the 2016 debate as we head into the presidential election. I think the Affordable Care Act goes a long way in helping sort of solve some of the egregious behaviors in the past, but there's still a long road ahead. I liken it to being sort of the first step out of our healthcare wilderness, which we've sort of been wandering around in for a few decades. And I think there's still remaining some really big systemic flaws that have to be addressed, and the largest of which is simply cost. We spend far too much per capita per year on healthcare for the kind of outcomes that we get. The headline that I did earlier this year was we've now eclipsed, in this year, we will eclipse $10,000 per person per year that we spend on healthcare. And so and even with that, there's over 30 million, regardless of who you look to, there's over 30 million that are still uninsured. And at $10,000 per person, it's like we don't have universal coverage for that. And so there's some systemic issues that I think we're going to get to here in the next election.
Well, and I think those are some really good points, and that, along with Bernadette's and Janice's points, talking about the cost per person, talking about family, being able to have those tough conversations. Dr. Larry Van Horn from Vanderbilt was outlining some data recently about the amount of cost and the amount of duration of life support or extra activities that happen for family members who weren't present and weren't having those discussions with their family versus those who had a caregiver that was present throughout the disease states or the end-of-life state. And when it came to those tough end-of-life decisions, those who had a caregiver present were more likely to allow their loved one to have a end-of-life process that was more amenable to them versus feeling guilty and trying to extend that life to make up for lost time and missed conversations. And so I think we've got to be able to engage in that health literacy, those tough conversations as well. Deryk, on this cost thing, you want to wrap us up here with how do we get there in a cost-effective manner, and what are some good...
I really see the costs and the health outcomes. The last question, they're pretty much wrapped together. And I see it in different buckets, right? We can help clinicians and healthcare delivery and allied care professionals make good decisions. We can help patients get more engaged and make good decisions, and we can help communities in terms of stakeholders more broadly. So there are others. We can talk about employers and others, but these are three major components of this, and each one of these groups needs really good data, they need analytics, they need insights, and then they need sort of, practices, programs, evidence-based knowledge, tools to make good change. So, there's sort of a big picture, way to look at all of this. And what we want with clinicians, of course, is really just more personalized clinical interventions, and that's what they want too, but they need to have all the data to be able to provide that. And for patients, as I say, it's for sure access to data, but it's really getting into health beliefs and motivations and working with people around tough things like mental health and motivation and where they want to go. But I'll just take one more moment, if we've got it, on the community health side and just give another example, because the question was, how do we really get at cutting some of the costs and things, and I think maybe the way to look at it is re-engineering. If I was going to put it in one word, it's re-engineer the processes, not just trying to accelerate what we're already doing. And I'll give you another example, a little different than the San Francisco one, and that's in Hawaii, where they had really high emergency room rates associated with bacterial pneumonia, and these are really expensive. I mean, these are over $10,000, hospitalizations on average. And so that, once again, found that vaccination rates were pretty low, much lower than healthy people 2020 rates, and targets, I should say. And so then they looked up at various best practices and found that there are vaccination programs that could be put into place inside the walls of the hospital, as well as out in community centers, churches, and other kinds of places. And the result of that is sort of modeled out to be extremely positive on a return on investment, but there's no motivation. I mean, there's good intention, but there's no financial motivation to put that broad-based program into place. In fact, the hospitals probably make more money if people come in with their bacterial pneumonia, unless it's unreimbursed care. So it's a very complicated kind of formula. Here's the point. For someone who is hospitalized for bacterial pneumonia, typically over 65 years old, that's a very unpleasant experience. That is no fun. It's very expensive to the system. And we know that with vaccinations, we can be very effective on reducing these rates. But we still don't have something that basic more uniformly in place. So that's the kind of thing where we can put those kinds of programs into place and get fairly quick returns on investment, as long as we align the financial investments incentives to get that kind of work done.
That's great, Deryk. I think when we talk about this complex matrix, I am thrilled, Deryk, Dan, Bernadette, Janice, to be thinking through these things and knowing we've got folks like yourselves really at the tip of the spear thinking through this and having the courage to have a public dialogue about this. So I really appreciate your insights. Thank you everybody else for joining us today. For more information about Xerox Healthcare Provider Solutions, you can always visit us at www.services.xerox.com and search for Healthcare Solutions. Thank you. I'm Justin Lanning, and this was the Xerox Ask the Experts Population Health Hangout. So thank you, and enjoy the rest of your day.